Once again, welcome to this blended online training course on child and adolescent health in humanitarian settings. I am Khalid Siddeeg. I am the Regional Advisor for Child and Adolescent Health here in the Regional Office of WHO for the Eastern Mediterranean region based in Cairo. And I am so pleased to be with you today on Module 3 to address the issue of respond. Module 3 will be divided into two parts, part 1 and part 2, because the module is a bit bigger than other modules. As you all know that we are having this training based on the operational guide for child and adolescent health in humanitarian settings, the guide that we launched here in WHO-EMRO in 2022. And the guide is organized around 4 interconnected programmatic action areas. Those areas start from coordinate, then assess and prioritize, and we have finished those 2 areas in the previous 2 weeks. Today, we will be looking at respond, which is the third module, and is mainly about how to plan and enact in a coordinated way to make sure that a set of activities is implemented addressing child and adolescent health priorities in humanitarian settings. This module in the operational guide, it starts from page 45. And in this part 1, we will be covering only established service delivery structures. And when we start deciding on essential service packages, we will finish up until nutrition and food security. And next week, we will continue. These are the areas that will be covered during this week part of the respond module. And starting from established service delivery structures, it is well known that during emergencies, similar to the normal settings, we are still using the 3 levels of care for healthcare services. We need to have services provided at community level. We need to have services provided at PHC level and also at hospital and tertiary care level. At community, this is the care at community, at household, and when we say community in emergency settings, sometimes this also includes camps. And these types of services, they are usually provided through community health workers, community health promoters, and these types of cadres, while PHC care provision depends mainly on the country and the context. In some countries, we have PHC facilities run by doctors, but in others, they are run either by nurses, midwives, allied health professionals, health assistants, and so on. Hospitals are usually having full range of medical, nursing, diagnostics, and allied health professionals that are providing the required services. What are the challenges that we face while delivering child and adolescent health services during emergencies? We know very well that we have challenges related to service disruption and also facility destruction. Usually we have set of promotion and prevention services that are in place in normal supply chain is also being affected during emergencies, and issues of access, for example, to power, to water, electricity is a big issue during emergency. And as we have seen in many circumstances, infrastructures, roads, railways, they have been also destroyed. And people movements, population movements, and crowded population concentrated in certain areas. And in many cases, we have seen very rapid urbanization because people are moving towards big cities. In other circumstances, also, we have seen people moving out of cities towards the rural area. So population movement is a big challenge that faces the delivery of child and adolescent health services. Competing priorities, and we have seen this, for example, in Gaza, just in one of the recent crises we have in our region, where in the first few months of the crisis, the focus was on trauma management, was on injuries and emergency care. And that came at expense of maternal health services, newborn health services, child care, and so on. So it led to neglecting other types of essential services. And usually we come at later stage and we realize that we should have done something from the start. The security and safety, and mainly for health worker safety and security, it affects the provision of services very significantly, especially in war. So those needs of children and adolescents do change. So that means we need also to change our modality of work, our platform of service deliveries, our scope of practices, so as to fit the new needs of children and adolescents. For example, we can start using outreach services, we can start using mobile clinics. In some areas, we rely on community health workers heavily. We rely on house-to-house service provision or immunization services, as opposed to facility-based services that we have been using in normal settings. So these are the proposed actions for improving the health service structure during emergencies. And these are just examples of proposed actions. And as we always say that, please, based on your context, you can come up also with your own actions that to be implemented. We are just guiding you and giving some recommendations. Coordination is an essential step that we need to start with. We need to make sure that cluster, the health sector leads are coordinating and advocating for child and adolescent health priorities. And this is usually done through the working group that we proposed earlier in coordinate module to have either RMNCH or CH working group. We need also to review and adapt the service delivery because, as we said, we need the service delivery contents and platforms and modalities to be fit for the purpose. And it is extremely essential to engage the community. We cannot plan for services provided to the community without the community, especially women, young people, adolescents. We need to have them with us from the start while designing and implementing the service deliveries. And we all know that with emergencies also come some opportunities. We need to analyze the threats and opportunities that we have in order to improve reaching out to population, to see what we can use either to have mobile clinics in certain settings, or in other areas we can improve access to fixed facilities and so on. So this analysis of opportunities and threats is of utmost important. These are also few of the proposed indicators for health service structure. We need to measure whether the working group and partners have worked with health cluster to review the service delivery capacity and develop their own action plan for child and adolescent health. And also we have some indicators on availability of health services and health facilities. For example, availability of PHC facility for 5,000 population, of a community health worker for 2,000 of population. So are the indicators that people agreed upon, either based on sphere guidelines or based on the national guidelines in the country. And another example is the population within 5 kilometers of a health facility. All these indicators are examples of indicators we can use to measure and improve health service structure. Step number 2 is on, after improving and agreeing on the health service structure, we need to decide on what essential service package that will be provided. There are several considerations to take into account while deciding on the contents of essential service packages. So we need essential service package that will be delivered in all levels of care at community, at PHC, and at hospital level. And also, we need to address the needs of children at all ages. We don't need to focus only on newborn while neglecting under 5, or focusing on newborn under 5, but neglecting 5 to 9 and adolescents. And we need also to make sure that those service packages are based on our assessment and prioritization that we have earlier applied. So based on those priorities, we need to define our services accordingly. And those services usually needs to be defined during the preparedness phase. We need to put them in place during the response phase, and to expand them and to add more and more during the recovery phase. There are priority areas for newborns, children, and adolescents across the age groups. We need to be fully aware of those priorities in order to define the services that will be addressing these priorities. For example, for newborns, issues like prematurity, sepsis, birth complications, caring for small and sick newborn, they are important areas. That means we need to improve our immediate care practices around the time of birth. We need to improve early essential newborn care and caring for a small and sick newborn. While for under 5 children, it is usually pneumonia, diarrhea, malaria, and malnutrition. These are the main killers and risks for under 5 children. So prevention is important: immunization, wash facilities, nutrition interventions, and also integrated case management, like integrated management of childhood illnesses, or at community level, integrated community case management. For children at 5 to 9, mostly the priorities looks like the under 5 ones. We're still having infection, but here intentional injuries and mental health issues start to appear. We need to make sure that we are having prevention and treatment of common illnesses in place. Management of chronic conditions and psychological well-being is there. For young adolescents, 10 to 14, they are something in the middle between the childhood and adolescence. So they have unintentional injuries also, and injuries in general coming very prominent here, in addition to the infection and mental health issues. So we need to have a full range of services in place. For older adolescents, 15 to 19, injury continue, and injury actually here increased to be a burden more and more. But mental health issues, substance abuse are essential areas to address. While for girls in 15 to 19 years, pregnancy, childbirth, and sexual and reproductive health issues in general are also coming high and high in our priority list. That means we need to make extreme emphasis on safety and violence and injury prevention. And for 15 to 19 girls, we need to make sure that they have good access to sexual and reproductive health services, in addition to the overall psychosocial and mental health services. Within the range of essential service packages, we have a set of 10 areas or fields that are proposed for service delivery during emergencies. But again, it is up to the implementers on the ground to decide on the service packages based on the context, based on the priorities, and we are trying just to provide the guidance. Starting with acute conditions, we know that besides trauma and injury, acute conditions are the leading causes of death in all age groups, actually, in humanitarian emergencies. Diseases like diarrhea, pneumonia, measles, malaria, meningitis, dengue fever, they are all leading to huge number of deaths in humanitarian settings. Also, newborn, they have their own acute conditions, and newborns are in particular at high risk of death around the time of birth. And this is related to antenatal care, related to care during birth, whether it is being attended by a skilled birth attendant or not, where are the evidence-based practices were implemented or not, and so on. So we know the main causes of death are prematurity, infection, birth complications. So we need to make sure that the immediate interventions are in place to save newborn during emergencies, and they are simple. They are extremely simple and easily to implement. We need to have a skilled birth attendant. We need to make sure that it is done in a clean environment. We have thorough drying. We have timely cut of the cord. We need to keep the baby warm all the time with skin to skin contact. We need to start early initiation of breastfeeding and continue breastfeeding, and to teach the mother how to monitor the danger sign, and also to teach the care provider how to monitor the danger sign. So these are the simple measures that, just examples of simple measures that could be implemented to make sure that we are having proper response to acute conditions. Few actions are proposed in the guide to address acute conditions. They are mainly addressing the prevention part and the care provision or case management part. For the prevention part, we need to make sure that areas like water and sanitation and vector-borne control measures are in place. Also, vaccination is a big intervention that we always rely on to prevent acute conditions and safe delivery and recognition of illnesses in children is important. Health education and health promotion messages focusing on early care seeking behaviors, advocating for availability of services is another area of importance for us. This is for prevention. For the case management, we need to address case management at all levels, at community case management, at primary health care, focusing, for example, on IMCI, integrated management of childhood illnesses. And we need to make sure also in other levels that the SOPs, the protocols and standards are implemented at hospital levels. Triaging is an intervention that extremely needed during emergencies, with crowdedness at facilities, with the overwhelming number of patients at health facilities. And we need to improve the referral care quality. And this is by creating communication and transportation systems that are linking all the levels of care together. The indicator that is proposed in the guide that our working group, the CH or RMCH working group and partners, they have already outlined their acute care priorities for children and adolescents and advocated for those priorities within the health cluster, and managed to successfully integrate those priorities in the cluster plan, and then ultimately to implement those activities proposed in the plan. Coming to the chronic conditions, and I'm sure in most of the settings that you are coming from, non-communicable diseases and chronic conditions are becoming more and more higher in the agenda of policymakers and in the community interest as well. We know that chronic conditions, they last for long period, so they necessitate prolonged care, and they affect families. If in a family there is a child with diabetes, a child with cancer or with renal impairment, the whole family life is does change to fit the need of this child. And there is also specific health care needs in terms of diagnostics, in terms of compliance to treatment, in terms of follow-up, and so on. So some of the key actions that are proposed for chronic illnesses, we need to make sure that we are having our working group members cooperate with all partners to ensure the access of care for chronic illnesses. And for these specific conditions, the involvement and engagement of children, of adolescents, of their families is crucial, because these are the entities that are responsible for the care of children before the crisis, so they need to continue that during crisis. So they need to be informed about where they can get the medicines, how they are affected by emergency, how does emergency affect their children with chronic illness, and so on. Sharing data on chronic health conditions and disabilities, especially during the need assessment and also during the response, is important. And continuity of treatment is key for this group of patients, because we know the disastrous impact of interrupting treatment, for example, for diabetes or for renal dialysis or for cancer treatment. So we need to make sure that we have, in the preparedness part, we have already put in place continuity of treatment as a priority. These are the indicators that are proposed, that our working group has identified the priority chronic care needs and essential medicines and supplies that are needed, and communicated them to the providers, to the beneficiaries, and to the health cluster, and to make sure that the adequate medications for children and adolescents are being measured as a key indicators for chronic conditions. During emergency also, the issue of child safety and protection becoming more and more important. Unintentional injuries before crisis, they are a leading cause of death among from 5 to 19 years of old. And during emergencies, due to many reasons, this burden usually increase. And we know the direct intentional injuries also affecting children and adolescents very much. We have seen in Gaza the high proportion of children affected directly by crossfire, by airstrikes. We have big number of children, of adolescents who died due to direct attacks. We have also seen this in Sudan crisis, and also we continue seeing it in Yemen and other places. So also conflict-related death is a big burden we need to look at. And we know that violence usually increases during conflicts, during crisis, because disasters usually put people at risk of high prevalence of violence. And sexual and gender-based violence is not an exception. Whenever we have a conflict, we have instability, we have emergencies, sexual and gender-based violence increase, in addition to so many other concerns like trafficking, recruitment to armed forces, and so on. So the actions here will be mainly relying on good cooperation with the cluster, with the protection cluster, because we know very well that we work in a multiple cluster approach. So the protection cluster is the cluster that deals mainly with safety and protection issues. We need to make sure that we in the health cluster, or we in the working group under the health cluster, are collaborating with the protection cluster. We need also to contribute to their activities. We need to advocate for this age group within the protection cluster, and together we develop our coordinated plans to address all these safety issues. The indicators, one indicator is that the working group and partners have developed and adopted the child safety and protection measures within their organization and across the organizations. And also the working group works collaboratively with the protection cluster. This is very important to support the full integration of child safety in humanitarian action. Coming to the fourth area of work under the service package, which is disease outbreaks and immunization. Again, we have seen it in many emergencies. Outbreaks find suitable environment during emergencies, during the disruption of normal lives, normal environment, and degradation of the environment, water sources, sanitation. All this leads to so many outbreaks and epidemics. And in particular for the child health area, measles is a major threat. We need to make sure that we have full immunization coverage against measles. We have all the prevention measures of measles are in place, and also the case management and the skills of care providers and the facilities supplies are in place. So measles is one of the well we always fear during emergencies, in addition to all other vaccine preventable diseases. And we need to make sure that we are having this, because outbreak response is not a business of one sector. We need to have collaboration across all sectors to address uh, outbreaks. These are the few actions proposed here. For more details, please refer to the operational guide. We need to make sure that we are preparing for outbreaks. From the preparedness part, you cannot start that after the occurrence of the crisis. Immunization as a very important intervention need to be in place as a preparedness, response, and recovery measure. And also the supplies related to vaccine, the cold chain, the electricity, the power, these are all important components of our response to disease outbreaks during emergencies. And we need to make sure that our system properly screen children who are attending health services for whatever reason they are attending the health services. We check them for immunization status and try to provide the vaccines that are missing to those children. So the indicators for the disease outbreaks and immunization, we need to have our working group and partners have contributed to creation and dissemination of the multi-sectoral outbreak response plan. And also our working group and partners supported the re-establishment of the national or sub-national immunization program. We have some specific indicators such as case fatality rates and national immunization program establishment. They have specific indicators, but for more indicators, please refer to the operational guide for more details. For the fifth area, and it is the last area for part one of the response module, is on nutrition and food security. And also in emergencies in our region, we have seen how significantly the nutritional status of children was affected by emergencies. And usually we cite Yemen experience in this, because in Yemen, malnutrition after war, the prevalence of malnutrition after war has increased dramatically. And we have also a video in the previous module, and it will be kept also for this module. Please refer to the video from Yemen on how they worked and how they dealt with nutrition problem in terms of coordination, assessment, and also response. For example, we know that the severely malnourished child is almost 9 times more likely to die as compared to a well-nourished child. This has put us in a great challenge of addressing malnutrition priorities during emergencies. These are also the examples of the actions that are set for nutrition and food safety. Again, remember here we have another cluster, which is the nutrition cluster we need to work with. So our working group needs to work with the partners and the nutrition cluster to have planning and implementation of nutrition interventions in place. We need to make sure that our system, our strategies, our protocols and guidelines addresses severe acute malnutrition at our facilities, both at inpatient and outpatient level. We need to have micronutrients, vitamin A and other micronutrients are provided and also supplied to the age groups that are targeted by this intervention. And young infant and young child feeding policies, practices, and strategies are another important interventions within the overall umbrella of nutrition. We need to have interventions like early initiation of breastfeeding, exclusive breastfeeding, complementary feeding are in place. We are promoting these interventions. We are diminishing the effect of artificial milk producers on our families, because we know that families during those crises are in a vulnerable situation, and it will be easily to take them into direction of stopping breastfeeding and relying on other sources of food for their newborns and infants. And we need to make sure that our pregnant ladies are also receiving proper feeding and nutrition. These are the key indicators of nutrition and food security. The working group and partners have already supported the nutrition cluster to assess, plan, and implement nutrition interventions and programs. We have some specific also indicators, and as we said, these are just examples of indicators, and you need to refer to the operational guides for more details and to the guiding documents of the country for even further details. One of the examples just to share here, the feeding program outcomes, because we always aim at having less than 3% of deficits, and those who recover to be more than 75%, while those who did not reach the services or defaulted to keep at less than 15%. You will have all the resources and tools related to this part of the guide on page 74 to 77. And for all other questions, comments, please do not hesitate to reach out to myself, EMRO, to my colleague Kim, who is also the focal point for the training on child and adolescent health in humanitarian settings. And I would like to thank you so much for listening at the end of this presentation. Thank you so much.